Hello everyone, I'm glad to be here to report a prospective study from our team, Efficiency and Safety of Ultrasound-Guided Radiofrequency Ablation for Primary Hyperparathyroidism. We know that the traditional treatment of PHPD mainly relies on parathyroidectomy, but the surgery has relatively high risk of complications. In recent years, minimally invasive thermal ablation techniques are trying to treat PHPD. Today, there is a lack of prospective studies on thermal ablation of PHPD. Based on this situation, we initiated a prospective project to explore the efficiency and safety of RFA in the treatment of PHPD. Firstly, let's review the types of PHPD. According to the presence or absence of symptoms, PHPD can be divided into symptomatic and asymptomatic. According to the level of blood calcium, it can be divided into hypercalcemic or normal calcemic. Let's come to the materials and methods. In our study, there were 48 patients who made the inclusion criteria. One patient's parathyroid gland was invisible on ultrasound imaging. 3 patients' parathyroid lesion has suspicious malignant features on ultrasound images. In 4 patients, the location of parathyroid gland was technically inaccessible. Another patient had negative maybe or negative NFA-PDH test. All of these patients were excluded. Then 39 cases were finally enrolled into our study. Inclusion criteria were all symptomatic PHPD and asymptomatic PHPD, meeting one of these criteria below. One single enlarged parathyroid gland detected by ultrasound and contrasting Hangzhou neck CT, high positive may be on SPECT images, or negative may be on SPECT, but the gland conferred by parathyroid tissue by FNA PHD analysis. The exclusion criteria include secondary or tertiary hyperparathyroidism, history of parathyroidectomy or ablation for hyperparathyroidism, hoarseness or any vocal cord movement abnormalities, and severe coagulation dysfunction or cardiopulmonary dysfunction. Important exclusion criteria on imaging features include a nodule with suspicious malignant features, such as irregular shape, intranodular calcification, infiltrative water, a maximum diameter more than 30 millimeters. Another imaging feature in exclusion criteria was technically inaccessible location, including depth between parathyroid and surface of body more than 30 millimeters, retrotracheal parathyroid, substernal parathyroid, and so on. Let's take a look at the ablation process, which includes 4 steps: local anesthesia, water isolation, and ablation, and contrast-enhanced ultrasound evaluation. This is an enlarged parathyroid gland, which is located behind the thyroid. The inner side is close to the trachea and esophagus. The outer side is close to the common carotid artery. In order to conduct ablation safely, we need to inject isolation fluid around the enlarged parathyroid to prevent thermal burn to the important surrounding organs. Firstly, inject the isolation liquid into the lateral and posterior area of parathyroid. The liquid was injected is 5% glucose water. Since the inner side of parathyroid is close to the trachea and esophagus, we need to inject isolation liquid into the median area between the parathyroid and trachea in another direction. Generally, when the width of isolation fluid is more than 5 millimeters, heat from RFA can be isolated effectively and surrounding organs could be protected well. Then, we insert RF electrode on the guidance of real-time ultrasound. Firstly, puncture the ablation electrode to the posterior median edge of the parathyroid. When the area around the electrode tip is fully vaporized, pull the electrode tip a little along the long axis of the electrode till the vaporization area covers the entire parathyroid completely. This technique we adopted is the moving shot ablation technique created by Professor Baek. After pull out the electrode, we conduct a contrast-enhanced ultrasound evaluation immediately. Contrast-enhanced ultrasound shows no enhancement of the entire parathyroid, indicating that the enlarged gland has been destroyed completely. We evaluate therapeutic effects according these acts below: technical success, biochemical cure, clinical cure, recurrent PHPD, persistent PHPD, and EPPH. Let's look at our results. All 39 parathyroid nodules were treated with RFA in a single session. 38 nodules were completely ablated. The technical success rate was 97.4%. One nodule was not completely ablated. As the patient developed hoarseness during RFA, the patient also developed into recurrent PHPD. The graph shows the changes in IPDH, calcium, and phosphorus value and nodule volume before and after RFA in patients with PHPD. A level of PDH, calcium, and phosphorus value were almost normal after 1 year. PDH decreased from 178 before ablation to 44.6 12 months after ablation. The blood calcium decreased from 2.76 to 2.36. Lots of phosphorus rose from 0.84 to 1.14. The volume of parathyroid gland gradually decreased or disappeared after ablation. We can see the volume of parathyroid gland in this patient decreased from 0.46 milliliter before ablation to 0.06 milliliter 3 months later, and further reduced to 0.03 milliliter 12 months later. The symptoms of dizziness, fatigue, and anesthesia were relieved rapidly and disappeared after ablation, and there were no new cases with fragility fractures and nephrolosis during the 12-month follow-up. At 6 and 12 months post-RFA, the overall biochemical cure rate in our study were 82.1% and 84.4% respectively. Then overall clinical cure rate was 100%, 96.9% respectively. In the PHPD with different blood calcium levels, the treatment effect of normal calcium PHPD is more stable. Both biochemical cure rate and clinical cure rate of it reached 100%. Only one patient in our study was diagnosed with recurrent hyperparathyroidism due to the increase of blood calcium level 7 months later after ablation. In this case, the ablation was terminated due to the hoarseness during the ablation process. At that time, small error in the parathyroid showed high enhancement in contrast-enhanced ultrasound, while the small error with high enhancement expanded significantly 1 year later. The changes of PDH and blood calcium in patients cured after ablation often show different changing trends. Generally, the blood calcium decreased to a normal level stably after the ablation. The level of PDH decreased significantly 20 minutes and 1 day after ablation. It begins to rise 3 days after ablation and rebound to the peak level 1 month after ablation. It usually reaches about 38% before ablation. After the peak level at 1 month, the PDH starts to decline slowly. No treatment is needed during this time. The incidence of death at 1, 3, 6, 12 months after ablation was 44.7%, 34.3%, 15.8%, and 12.5% respectively. Here summarize the cases with complications in our study. There were 2 cases with hoarseness, which were back to normal within 3 months, and 7 cases with hypokalemia, which returned to normal after calcium supplementation. Others with minor complications were recovered spontaneously within a few days. This study has several limitations. First, it was preliminarily conducted at a single center. The follow-up period was not long. The sample size was not large, and owing to the technical difficulties, we did not use RFA to treat relatively high-risk nodules, such as those that were too deep or located in the carotid sheath. In conclusion, minimally invasive RFA is an effective and safe treatment for patients with PHPD, and may be an alternative treatment for patients who cannot tolerate or refuse to undergo surgery. I would like to take this opportunity to thank Professor Baek from Asan Medical Center in Korea for his guidance and help to our project. I would also like to thank the Korean Journal of Radiology for giving us this valuable opportunity to introduce our project here. If you have any questions, please feel free to contact us. Hope that we can promote the standardization and development of parathyroid ablation together.